All ACE inhibitors and angiotensin receptor blockers have potential side effects, as do all drugs. The main ones that I worry about with these classes of drugs are laboratory abnormalities, so specifically elevated potassium levels, elevated serum creatinine levels, are the two biggest ones. So I do monitor those lab values after initiation of an ACE inhibitor or an angiotensin receptor blocker and periodically while patients are on therapy. From that standpoint, we expect to see some elevation in those numbers with initiation of therapy or dose escalation. And so if potassium levels get into above 5.5, I start to get cautious, and certainly above 6, I would recommend reducing the dose. In terms of changes in creatinine, I typically will tolerate somewhere between a 20 and 30% rise in creatinine before I think that that's too much and will reduce the dose or stop the medication. So that's from the lab side. From the patient side, in terms of what to expect for side effects, the most common thing that we see is cough. So sort of a dry, persistent dry cough, not associated with a cold or anything like that, but a persistent dry cough. And for those patients, sometimes switching class of medications, so switching from an ACE inhibitor to an angiotensin receptor blocker, will be enough to get the benefit of having that class of drug on board without the cough side effect. So that's fairly common. We do have patients, particularly younger patients, who have low blood pressure and become symptomatic from that, whether that's fatigue or decreased energy or dizziness, especially dizziness with standing, that we'll see. And those types of side effects can be harder to quantify. So typically it's a conversation about how those symptoms are impacting the life of the person who's experiencing them. So if it's making it so that a kid who has been active and doing sports is not able to participate in their sports, or a kid who was previously able to, hop out of bed in the morning and go to school and was doing great, and then is not able to sort of engage in those usual activities, I will try to either reduce the dose or to maybe even stop the medication and see if symptoms get better off of the medicine. The hard part about those symptoms, of course, is that they're not measurable the way that potassium and creatinine and those things are measurable. And so it really is a conversation between the family or the patient and the physician to determine what the best course of action is there. And then I think the other really important side effect for women on these medications is that they can cause birth defects if you become pregnant while taking the medications. And so that's something that I always talk to young women about who are starting these medications, to be sure that they're aware of that as a potential side effect. So I think this is a really difficult conversation for physicians and for patients. I always like to think of it as the physician is sort of the expert in the disease and the family is the expert in the patient. And their goals are aligned in that both want the disease and the treatment to have as little impact on the patient over the course of their whole life as possible. The hard part is that as the physicians, we want to do everything we can now to prevent kidney disease in the future. And so we feel responsible to be advocating for the best tools we have, the use of the best tools that we have to prevent kidney disease in the future. We don't have a lot in our toolbox is part of the problem. And so there aren't a lot of alternatives at this point to ACE inhibitors and angiotensin receptor blockers that we have to offer. And we want to do something because we want these young kids to not progress to have chronic kidney disease and end-stage kidney disease. That said, I think the parents and the kids, as the experts in what their experience is, are sort of also obligated to make sure that what we're doing now doesn't impact their psychosocial development, their ability to participate, their ability to get their education, all of these other important tasks of adolescence, which is usually when we're having these conversations. So I think it really is about having sort of saying, this is what would be tolerable to us. The way it is now on, whatever, 20 milligrams of lisinopril, not able to get out of bed in the morning is not tolerable. But what if we, reduce the dose by half and saw if that was functional, or sort of going back and forth on what might be work for the patient and the family that would also try to work for preventing kidney disease over the long term. But I think it is really a real challenge. And ultimately, the family and the patient decide whether the patient takes the medicine. The doctor makes the recommendations, and the family has to decide what to do with those recommendations. So I think that at varying stages in the disease process, there are probably different needs in terms of the communication between the nephrologist and the pediatrician. For a child with normal kidney function and normal blood pressure and maybe on a low dose of an ACE inhibitor, it's important that the primary care doctor knows what medicines the patient's taking, maybe what their most recent labs are, those sorts of things. But the more tight communication that's needed when a patient has advancing kidney disease is probably not necessary when you're in that really early preventative stage. Most specialists and consultants are sending at least their clinic notes to the pediatricians on a regular basis. That's a sort of professional expectation. So you would expect those notes to be available, or to be available to the patient so that the patient could move them over to the pediatrician if the systems don't communicate well. So that seems like the minimum amount of communication that's required. I really think that patients and families should not be stuck in the middle between varying recommendations between their physicians, and that if that does occur, that the physicians ought to have a conversation between the two of them to decide really what the best course of action is. I think given how rare Alport syndrome is and how rare all kidney disease is in children, that many pediatricians, they're so capable of taking care of a really wide variety of disease processes, but the kind of expertise that it takes to take care of children with kidney disease, especially children where we know that they're at high risk for having progressive kidney disease over the course of their lives, I think most pediatricians, they don't have enough patience to really have the necessary experience to give strong opinions about that. What they can comment on is this medicine is impacting the kid in some other aspect of their life, because they may see that in a way that's different than what the nephrologist sees. And so I think that when there's differences in opinion about medical recommendations, I think it's really important that they talk directly to each other, not through the patient. I think everybody should take their medicine from the doctor point of view. Everybody should take their medicine every day as prescribed, unless you have a conversation with your doctor about the specifics of your scenario. So I think that's the first thing. What I can tell you what I do in my practice on an individual case by case basis with my patients is I recommend that if they are dehydrated or at risk for becoming dehydrated, so that can be anything, a diarrheal illness, a long hot streak, a big sports event that's coming up, those sorts of things, that they either reduce their dose or hold their ACE inhibitor or ARB for a day or two. I think based on the data that we have about the way that these medications work to prevent kidney disease over time, we don't have specific prospective data that taking it every day is better than missing a couple days here and there for an event that you otherwise might have a really big rise in creatinine if you were to be dehydrated and on these medicines. So I think the most important thing is to have that conversation with your doctor about what are the circumstances under which you would hold, stop, reduce the dose, and not try to manage it on your own. So I'll start with the first part about changing classes of drugs. I think we do see fewer side effects with the angiotensin receptor blockers compared to ACE inhibitors. And I think there are better data to support the use of ACE inhibitors in preventing progression of Alport syndrome. So we generally use that as our first line medication. But we don't have a good reason to think that angiotensin receptor blockers would be significantly inferior to ACE inhibitors in terms of the efficacy. So in my practice, I generally start with ACE inhibitors first. And then if there is intolerance, whether that's low blood pressure or cough or, high potassium levels or anything else, if I think that we are not able to achieve sort of a sufficient dose of ACE inhibitor because we're limited by side effects, I will usually switch to an angiotensin receptor blocker. And I think that that's pretty standard practice. In terms of the difference between the individual drugs within a class, I tend to use the longer acting medications, so lisinopril and ramipril as opposed to enalapril or captopril. I tend to use those longer acting medications because I think the side effect profile is less, but if someone isn't tolerating, particularly from a symptom standpoint, isn't tolerating one of the medications, I will switch and see if they tolerate a different one. And sometimes they do, and sometimes they don't. And I have not been able to find anything in the literature or noticed anything in my practice about who tolerates what better. It seems to be very specific to the individual. And so I usually just keep trying until I find something that works for that individual patient. It really depends on what the goal blood pressure is for that particular patient. And we have different targets depending on how much protein there is in the urine. So that's, again, a conversation to have with your individual nephrologist about what is my goal blood pressure. In children, especially children with glomerular disease, typically our target blood pressure is less than the 50th percentile for their age and height. So it varies as they get older. So for kids who have persistent blood pressure above that goal, despite maximum tolerable dose of an angiotensin receptor blocker or an ACE inhibitor, that's when we add a second drug. And amlodipine that you bring up is typically my first choice as a second line drug in this group. I'll start with the second piece with the second question about who should be bringing these up. And I think we should all be bringing them up. So sometimes it's me, sometimes it's the patients. I think because the Alport syndrome community is so connected and aware of all of the trials that are going on, I think that it's probably helpful for patients to ask if there's studies that they're eligible for. And if they are not getting that information from their doctors, then to ask their doctors to look into it. Because it may be that some physicians are not as aware of all the things that are on the horizon. In terms of what questions patients and families should be asking before they enroll, I think one is to make sure that they have an understanding of how this drug has been studied in other kidney diseases and what the outcomes of those studies were. Typically, most of the trials to date, at least, have studied drugs that were originally studied in other types of kidney diseases. And so understanding whether this is a kidney specific treatment or an Alport specific treatment, I think are two separate questions. And so making sure that you understand kind of what you're signing up for and what the efficacy and what the safety has been in other studies. I think understanding whether these medications have been studied in children for other disease processes is important. And again, how has that gone in those studies? Because we are often in the kidney disease community late to accept the data that comes out of, especially the safety data that comes out of other studies. And so just knowing what is out there for these studies. And then I think that because Alport is a rare disease, knowing how many people with Alport syndrome they plan to include in the studies, because we can't make progress if we're looking at really small numbers. And so if you're interested in the clinical trial, there's real power in people coming together and enrolling larger numbers in a smaller number of trials, because we get more data that way than we do from having people spread out in small numbers in a larger number of trials, if that makes sense. We always take cause of disease into account when we're following kidney transplant patients. It informs our risk of recurrence, which we know in Alport syndrome is low. It informs our risk of other things and the rare occurrence of anti-GBM disease that we see after kidney transplant in Alport syndrome. But in general, we think that the outcomes in kidney transplant recipients who have their original disease as Alport syndrome do well or better than the general population that receive a kidney transplant. And so we don't generally use a different immunosuppressive protocol for patients who have Alport syndrome. That varies by center. What that protocol is varies quite a bit by individual center, but we don't have any specific more or less immunosuppression in this group than we would based on the typical factors that we use to make those decisions in all comers with end-stage kidney disease. There's a lot of debate about who should be on prednisone, and it is very center specific. And I would say that there is not 100% consensus for Alport syndrome or any other disease about the use of steroids in kidney transplant patients. So first of all, in pediatrics, there aren't a lot of studies looking at longer term outcomes with belatacept. And so there's currently a clinical trial in progress in children to look at belatacept post-transplant. So we don't have the data that we need to make those decisions in children right now. Our practice has been generally to transition kids who have intolerance of calcineurin inhibitors, so tacrolimus and cyclosporin for some reason, or have severe problems with medication adherence to belatacept. So that's not a cross section of our whole population. It's pretty specific on a patient by patient basis. But I'm hopeful that the studies that are being done in pediatrics now will inform our practice about who benefits from that over the long term. I think the thing that's hard in Alport syndrome in particular, as compared to other kidney diseases, is the variability in its course and all of the unknowns that families face in terms of timing of progression and the uncertainty about what is the best course forward. How do you weigh the side effects of the medications with the potential benefits, which you might not realize for years and years. And so I think finding support through groups like the Alport Syndrome Foundation, through your own community resources, whether that's your family or whoever else is around you that provides support, is really important as people navigate these really challenging issues. I think it's particularly challenging when we're talking about starting very young children on medications, for families to navigate those decisions. And so finding a physician who you can have a real conversation with about the data that we have, the data that we don't have, and how we make these decisions is really important.